All right, Dr. Mangan.
Great. Thank you. So good afternoon, everyone. As Casey said, I'm John Mangan. I'm one of the spine surgeons here at Rothman Orthopaedics. And today I'm going to be talking to everyone about common problems of the cervical spine. If it wants to advance. So just to share a little bit of background about myself, similar to what Casey said, that I was born and raised here in Delaware County. I'm from the Philadelphia area. I'm a graduate of the University of Scranton, and I attended Geisinger Commonwealth School of Medicine for my medical degree. I came back down to the Philadelphia area, and I completed my orthopedic surgery residency here at Rothman Orthopaedics at Thomas Jefferson University Hospital. And then after my my residency training, I went out to the Cleveland Clinic where I completed a combined neurosurgical and orthopedic spine surgery fellowship. And I'm back here at Rothman Orthopaedics, and I see patients at several of our locations, which I'll go through in a moment. And I serve as an assistant professor of orthopedic surgery at Thomas Jefferson University Hospital. So I currently see patients around the Philadelphia area, particularly in the western suburbs. I see patients in Glen Mills, in Bluebell, and in Wynwood, which is located at the Lincoln All Medical Center. And I operate currently at Riddle Memorial Hospital, which is in Media, Physicians Care Specialty Hospital, which is in Limerick, and I operate at Chester County Hospital, which is in Westchester. So today we're going to talk about two common spine problems that occur in the neck or the cervical spine. The first of which is spinal stenosis, which can occur in the neck and lead to a syndrome called cervical myelopathy. And the second of which is cervical radiculopathy, which we'll talk about. We'll go through the signs and symptoms of each of these diseases, how we work them up, what the natural history is, particularly of cervical myelopathy. And then lastly, we'll go through what the treatment options are for each of these problems. So to start, let's talk about stenosis. And what is stenosis? Stenosis is abnormal narrowing of the spinal canal. Now, stenosis can occur in the neck, or the cervical spine, the thoracic spine, or in the low back, which is the lumbar spine. The causes of spinal stenosis are very variable, and they change from patient to patient. Often it's arthritis or wear and tear of the joints around the spine. People can have herniated discs. Some people are born with smaller spinal canals than others, and we call that congenital stenosis. And then other people will develop degenerative disc disease, which is a form of arthritis where the disc wears out and leads to arthritis, which narrows the spinal canal. Now, when we look at the neck, we have an MRI here on the screen, which is looking at the side view or the sagittal view of the neck. I've outlined the spinal canal in red. And in the middle of the spinal canal, at the bottom of the orange arrow, is the spinal cord. And we can see that at the top, there's plenty of room between the red lines and the spinal cord itself. Now, the white area around the spinal cord is spinal fluid, and that's what bathes and protects the spinal cord. It's a shock absorber, so to speak. But as we get further down the screen or down the image, we can see that those red lines are actually touching the spinal cord. And that's what we call spinal stenosis. It's when the walls of the spinal canal begin to encroach in the middle, and they end up pinching, whether it's nerves in the lumbar spine or the spinal cord in the neck, and that's spinal stenosis. The other topic we're going to talk about today is radiculopathy. Now, most people, when we talk about radiculopathy, they think of radiculopathy in the leg, and people will commonly refer to that as a sciatica. So a sciatica can occur in the arm as well, and we call that a cervical radiculopathy. And that's when a nerve gets pinched as it exits the spinal canal. Now, when patients get a pinched nerve, that pain typically will follow the pattern that nerve travels, or we call that the dermatome. That's where the nerve innervates. So when people come in and they say they have arm pain, we try to follow their pain down their arm so we can try to match up which nerve we think is being impinged upon. Patients who have a cervical radiculopathy will also have neck pain commonly. So they'll have neck and arm pain. That all kind of ties into this idea of cervical radiculopathy. And cervical radiculopathy is caused by disc herniations. It can be caused by degenerative disc disease and arthritis. And we can see in the screen on the right here, there's kind of a different, there's a schematic that shows a different causes of radiculopathy, whether it's a disc herniation or arthritis that's developing around the facet, which they call hypertrophic facet here, or hypertrophic zygapophyseal joint. That's a different word for arthritis. And they're pinching on the nerves as they exit the spine. So next, we're going to talk a little bit more in depth about cervical stenosis. So cervical stenosis can lead to a syndrome called cervical myelopathy. Cervical myelopathy is the clinical syndrome or group of symptoms that occur when patients have chronic progressive compression or stenosis of their spinal cord within their neck. And this leads to spinal cord dysfunction that's a result of that long-standing pinching of the spinal cord. And the reason we're talking about that today is this is the most common cause of spinal cord dysfunction in adults. It has a prevalence that's been estimated to be between 2 and 4% of the total population. So this is a fairly common problem. It's more common in women than in men, and the symptoms tend to start in patients around their 50s. So this is really a disease of younger to middle-aged people, but we certainly have patients younger than the age of 50 and older than the age of 50 that will develop signs and symptoms of myelopathy. And this can be hard to diagnose, and it's often missed because in 30% or more of patients, they'll have no pain, but they'll begin to develop the signs and symptoms of myelopathy. And that's why it's important for practitioners and patients to know about this disease. So what are the signs and symptoms? So starting with myelopathy, initially patients will start with problems in their hands. They tend to start with numbness in their fingertips that's non-dermatomal. And what that means is it's numbness in their fingertips that doesn't follow a particular pattern of one single nerve. And eventually it can spread to being numbness in the hands that's more often, into the whole hand itself. It tends to happen during the day and at night. And as myelopathy progresses, patients will have loss of manual dexterity. And what that means is patients will have difficulty doing fine motor tasks. So commonly I have patients say it's hard to button shirts. I can't use a zipper anymore. I've been dropping objects, or I have handwriting changes. I had a patient today who told me that he's unable to use his belt anymore because he can't get the peg into the hole to use his belt. As myelopathy progresses, patients will develop discoordination of their gait, meaning that their balance is off. They're walking kind of staggered. They're walking kind of funny, and they have a fear of falling, or they actually are falling because their way that they walk is changed and their balance is off, their equilibrium is off. In patients who have severe myelopathy, patients will actually present with profound gait disturbance and hand dysfunction. They tend to come to my office already using ambulatory devices. And what I mean by that is canes and walkers, because they have a fear of falling, or they just feel that they don't have the security when they walk that they used to have, and they need that device to help them walk. Patients can develop bladder issues, such as urinary retention or overflow incontinence. And patients who have severe myelopathy that's untreated and that gets progressive, they can actually present with symptoms that are similar to that of an incomplete spinal cord injury. And in rare but severe cases, they can even develop symptoms such as tetraplegia. Next, we're going to talk about cervical radiculopathy and the signs and symptoms of cervical radiculopathy, which is that pinched nerve in the neck. So typically patients will present with pain, again, that follows the path of the nerve. And you can see on the screen here, there's a picture which kind of outlines the cervical nerves, C3, C4, C5, C6, C7, C8, and T1. And you can kind of see the path that we think about when we talk about those nerves. Patients will have either pain, weakness, or sensory changes in the arm. Again, commonly these patients will have neck pain. Approximately 80% of people have some form of neck pain when they have a radiculopathy. And patients will often tell me that they lift their arm up above their head. And when they lift their arm up, it helps to shorten the path of the nerve and helps to alleviate their symptoms. So that's another sign or symptom that people often notice or pick up on their own when they have a cervical radiculopathy. So when you have one of these conditions or symptoms of one of these conditions and you come to the office, what happens? So, it starts with the history and physical exam. I like to talk to every patient and see how long has this been going on for? What have you tried, if anything, to treat this so far? How much is this impacting your life? What activities bothers it? Are you able to sleep at night? Those are the things that we try to talk about. And then it comes down to the physical exam. I get every patient up and I have them walk in my office. I want to see how their gait is and how they're able to walk in space. For patients that I'm concerned that may have a cervical spine problem, I also have them try to do a heel to toe walk to see how their balance is, if they can walk in a straight line. And then I test the strength in their upper and lower extremities to see if there's any focal weakness or gross weakness in the arms or the legs. We check reflexes to see if they have diminished reflexes or hyperreflexia, which can be a sign of cervical stenosis. And then I think probably the most important part of the physical exam is I try to look for other reasons that people have pain and symptoms other than their neck. There's a lot of syndromes and symptoms that can cross over with other diseases that we want to make sure we're looking at and treating appropriately. When we think about neck problems, patients will often have rotator cuff tears that can cause neck pain or weakness in lifting their arm that sometimes gets confused with a cervical problem. And numbness in the hand can frequently be from carpal tunnel. And so we want to make sure that we look at all of those different options as possible diagnoses when we're seeing patients in the office. When patients come into the office for the first visit, we get x-rays of their neck to check their alignment of their spine. There can be a lot of information that can be gleaned from an x-ray. We have an x-ray, which again is looking at the side view of a neck here on the screen. And what we look at is the alignment of the bones of the spine. So when I do that, I follow the yellow line on your screen, which is the posterior cortical line. And I make sure all of the vertebral bodies, which is the gray kind of boxes that you see in front of that yellow line, those are the vertebral bodies, the front of the bone of the spine. And I make sure they all line up. I also look at the space in between those boxes, which is where the vertebral disc is. And I look to see, is the space between all of those bones about the same? Or has it been worn out in one area or multiple areas that may be causing some of the patient's symptoms? And lastly, we can see actually the size of the spinal canal from a bony standpoint by looking at a lateral x-ray. And the spinal canal actually lives between the yellow line and the red line on the screen, which is the spinolaminar line in red and the posterior cortical line. And some patients, again, have a narrower spinal canal, and that's how they're born. And we can usually glean that from an x-ray. So when patients have persistent symptoms, they have weakness in a major muscle group, or there's a concern for cervical myelopathy, typically we'll pursue getting an MRI at that point, which allows us to see the spinal cord itself and the nerves as they exit the spinal canal, and we can identify any areas of spinal cord compression or nerve compression. To give you an example of what that looks like, these are two pictures of the spinal cord in the neck. On the left here, there's an orange arrow which is pointing to a little bump or a dark circle there, which is a disc herniation that's causing what we call foraminal stenosis. And we talked about how spinal stenosis is when the tube where the spinal cord lives, and that's the main tube. And off of those tubes, there are little holes where the nerves leave the spine. That's the foramen. And sometimes people will get stenosis or pinching of the nerve in the foramen, which is what this picture is showing us here. And if we look at this picture on the left, you can see that there's a dark circle in the middle, surrounded by kind of a white circle on the outside. And the dark circle in the middle that's dark gray, that's the spinal cord itself. And the white circle around it is spinal fluid. And so there's no central stenosis here, or no central stenosis or cervical stenosis here. There's just foraminal stenosis from this disc herniation. This is what causes radiculopathy or arm pain. When we look at the picture on the right here, you can see this is a very different picture. Here we have the same anatomy. This is a cervical spine level. And the spinal cord here is this light gray area in the back of that circle that's getting squished by what looks like a disc herniation and arthritis in the front. And this is spinal cord compression. This leads to myelopathy and those gait and coordination problems that we were talking about earlier. So what's the natural history of cervical myelopathy, and why is it important for everybody to know about, and why are we talking about it? So cervical myelopathy is different than people who have lumbar stenosis or pinched nerves in their back. And the reason is patients who develop spinal cord pinching in their neck tend to have progressive symptoms. Those symptoms, like we talked about earlier, are numbness in the hands, loss of manual dexterity of their fingers and hands, as well as gait disturbance. And we've looked at this, we being spine surgeons, for years. And what we've identified is that patients will tend to get worse in a stepwise pattern. And what that means is that people will have symptoms, they will get worse, and then they'll kind of stabilize for a little while, and their symptoms won't change. And then they have an acute worsening of their symptoms, and then they kind of stabilize again, and then they get worse again, and then they stabilize again. This is that stepwise pattern that I was talking about. And that's typical of someone who has cervical myelopathy. Now, the issue with that is that when we treat cervical myelopathy, whether it's surgical or non-surgical, neurologic improvement is very variable. It rarely gets better with non-operative treatment. But even with operative treatment, patients don't always regain the function that they lost if myelopathy is left to be long-standing. And patients we know will have decline over time. We're not good at defining how long those areas of plateaus will be. So patients will have symptoms that begin and they may stay steady for a while before they worsen. And we don't have a good way of predicting how quickly people will get worse over time. Now, why that matters. So other studies have shown that long periods of severe stenosis within the neck are associated with demyelination or necrosis of the gray-white matter within the spinal cord. And what that means is people who have pinching in their neck that's been present for a long period of time, they can actually get death of the cells within the spinal cord itself. And spinal cord cells don't regrow, and this can lead to permanent damage to the cord itself and permanent functional decline for patients. In patients with severe long-lasting myelopathy or that spinal stenosis, the likelihood improvement with non-operative treatments is very low. So how do we treat this? What are the conditions that we treat? So here at Rothman, we take a team-based approach to treating our patients with neck problems. We have a great group of physical therapists, non-operative spine physicians, and surgeons who care for our patients with neck conditions. But the first-line treatment for cervical radiculopathy, so the pinched nerve in the neck, is non-steroidal anti-inflammatory medications. These include medications like ibuprofen and Mobic, and even oral steroids to try to help bring down the inflammation of the swelling around the nerve to try to help calm down patients' symptoms. We also typically initiate physical therapy here. The goal is to strengthen the muscles around the neck and to help stabilize that area of inflammation. Now, the good news for everybody out there with cervical radiculopathy is that 70 to 90% or more of patients will get better without surgery who have a cervical radiculopathy. It typically gets better over a course of 6 to 12 weeks. And these medications and therapy can help to mitigate symptoms as patients kind of have recovery from that radiculopathy. For patients who have persistent radiculopathy or severe symptoms, we can sometimes consider steroid injections into the neck, which can be helpful for helping us to diagnose the proper nerve root that is getting pinched. And it can also help alleviate patients' symptoms. By putting the steroid and some numbing medicine into the neck, we're able to both identify the nerve that's causing the pain as well as help to alleviate its symptoms. Not every area of the neck can be injected, so it depends where the problem is, but this is a good solution for patients who have persistent pain and symptoms. Next, we're going to talk about the treatment of cervical myelopathy. So cervical myelopathy is similar to the treatment of other conditions when patients have mild to early myelopathy. So this is some gentle numbness in the hands and maybe some slight gait discoordination, but they're not falling. Their gait isn't really off yet. They don't have any progressive symptoms. And we treat these patients with physical therapy, anti-inflammatory medications, lifestyle modifications, and close follow-up because we want to make sure that patients aren't progressing rapidly and go from early myelopathy to moderate to severe myelopathy. But these patients do very well treated with conservative measures. When we see patients with moderate to severe myelopathy, this is the myelopathy that tends to be more progressive or more aggressive. We get concerned that patients' symptoms won't get, we get concerned that patients will have progression of their symptoms and they won't get better with surgery. And what I mean by that is that patients who have profound gait disturbance that continues to get worse, surgery is really good at preventing it from getting worse, but it doesn't necessarily alleviate the gait disturbance that patients have at the time of surgery. So we try to intervene on patients with moderate to severe myelopathy earlier so they have less severe symptoms and they don't progress to more disabling symptoms. Again, as I said before, it's hard to predict how quickly patients will get worse over time. And we tend to recommend surgery for patients with moderate to severe myelopathy for fear that they won't have improvement after surgery. So we don't want to have them have severe symptoms prior to the operation. And what are the goals or the treatment strategies that we can do to treat cervical myelopathy? So the goal is to make more room for the spinal cord and nerves. to stop the progression of myelopathy or to treat patients' radiculopathy. Treatment options can include anterior-based surgeries, and this would include an ACDF or a cervical disc replacement. And that's when we go in through the front of the neck to remove the pressure off the spine. And we have posterior-based surgeries. These include a laminectomy and a fusion, which is when we take the pressure and the excess bone and ligament off the back of the spine, and we put in rods and screws to stabilize that area. And then a laminoplasty is a procedure that we use to open up the area of the spinal canal without having to fuse it. And we'll talk about each of these in more detail in a moment. So anterior cervical discectomy and fusion, or an ACDF as it's commonly referred to, is when we perform an anterior-based approach to the neck, and we're able to remove the bone spurs and the disc herniations that are pushing on either the spinal cord or the exiting nerve root that's causing a radiculopathy. Now, once we remove the disc and the herniations and the arthritis, we put a piece of usually cadaver bone graft in between those bones of the spine to try to get them to fuse together and to heal into one bone. Now, the reason we do that is because we want to prevent arthritis from coming back. And in order to access the back of the spine, we have to remove the disc. Typically, after we put that piece of bone graft in there, we'll put a plate on the front of the spine with a couple of screws in it. And that just aids in the fusion process. And it helps to increase the rate of fusion for those patients. Now, we can do this at one level in the front of the spine, or we can do it at multiple levels. And it works very effectively for treating patients who have anterior-based pathology. One of the other commonly performed surgeries would be a posterior-based approach, and that's a posterior decompression and instrumented fusion. And now this allows us to perform a laminectomy in the back of the cervical spine, where we take off the bone and ligament and allow the spinal cord to have essentially more room because we've taken off kind of half of the circle of the spinal canal. This works very well at alleviating patients' stenosis, and we're able to treat radiculopathy here as well. And we put in rods and screws in this area because we want to make sure that patients don't develop instability in their neck or the bones moving in abnormal places or abnormal motion after the surgery. So the rods and screws help prevent that from happening. And lastly, a laminoplasty is an operation that I perform which allows me to decompress the spinal canal. So we make more room for the spinal cord and the nerves within the canal itself. But I don't have to fuse the patient's neck. So this is a nice option to maintain motion within the neck and treat patients who have both radiculopathy and myelopathy. There is a more strict criteria as to which patients are candidates based on the alignment of their spine. But this is a great option for patients who have these symptoms to treat them without having to fuse their spine. And in conclusion, I know that was a brief kind of conversation about myelopathy and radiculopathy. These are both very common reasons to see a spine surgeon. Radiculopathy is going to tend to improve over time. Myelopathy tends to get progressive over time, and it can be progressive and it can be painless. And that's why it's important for patients and physicians to know about this disease, as it's fairly common and fairly commonly missed. And when we talk about myelopathy, again, myelopathy is very good at preventing the progression of symptoms, but it's variable at improving symptoms, which is why it's always better to be seen and evaluated earlier rather than later if you have any of these symptoms. Thank you very much. I know that was a brief talk. I'm happy to answer any questions that come up.
Thank you, Dr. Mangan. Great presentation. We actually do have a question that already popped up, and she wrote it right after this last section, so keep that in mind. What risks are associated with these surgeries?
So that's a great question. Obviously cervical spine surgery has risks associated with it. When we think about surgery in general, there's always risks of infection anytime you have a surgery, and that's relatively low. Particularly when we go through the front, it's an extremely low risk of infection. There's risk of damage to the nerves around the neck, including the spinal cord when we do these surgeries. The risk of that is extremely low. 1 in several thousand is the risk, but they're certainly not risk-free procedures, but a very low risk of having anything permanent damage.
Great. Next question is, what about the use of screws in osteoporotic bone?
Yeah, that's a great question, and that's something that we deal with every day as a spine surgeon, or as orthopedic surgeons in general, in treating patients with osteoporotic bone. Definitely makes things more challenging, as we want to make sure that we have good purchase within the bone, and we don't want hardware issues to happen because of that soft bone. And patients that have a history of osteoporosis, in the setting of progressive myelopathy, that's a conversation I have on a patient-to-patient basis about the risks and benefits of proceeding with surgery in the setting of osteoporosis. In patients with severe osteoporosis that are not, urgently needing a procedure or things like that, I think it's always good to get your bone health treated prior to surgery.
Thank you. Next question. Can you expand on some of the strict criteria for laminoplasty?
Sure. So laminoplasty works great for patients who have the proper alignment of their neck. So the traditional teaching for laminoplasty is that if you have too much kyphosis or forward bend in your neck, then laminoplasty may not be the best option, as it can fail over time because you lose some of the posterior tension band of your neck. So patients who have too much kyphosis or forward bending of their neck, your neck should be lordotic, which means it's kind of sloped backwards slightly. So patients who are too far forward, we try to avoid laminoplasty on. And patients who have what we call spondylolisthesis, where they have instability at one level of the spine, laminoplasty also tends to be contraindicated in those patients, as we worry that it'll fail over time because the bones aren't properly lined up.
Right. I think that is all the questions we have for today. So I appreciate everyone for logging in today and taking the time to be with us. Dr. Mangan, thank you for putting together this presentation. I'm going to end the recording now. Oops, excuse me, sorry.